So we are just under 10 minutes into the hour, and I'd like to ask one of our past presidents, Dr. Denise Hines Amin, to open up with our libation.
Thank you, Jamila. Thank you, sisters and brothers of New York ABSI, and to Dr. Lisa Whitten for your willingness to share, and to all of those present here today for sharing your energy and time. The pouring of libation is an act of spiritual grounding. It is a preparing a way for the opening of the way. It is a spiritual act between the living and our ancestors to whom we pay homage. It is a ritual usually involving the pouring of water, usually into Mother Earth. We are incubated in waters before we are born to this earth. Why do we pour libation? Many African traditions use libations as special gatherings, ceremonies they use it at, and rituals. It is a calling for spiritual approval and guidance in the opening of the way for what is about to be done, so that the best results are obtained. It is asking for the blessings and the best among us to help us and be with us. We pour libations because we are African, and we go back to our original traditions in times of need. Who do we call upon when we pour libations? Elders are highly respected among Africans who are descended people of Africa and are used to maintain balance and pace. We ask for their permission to speak at the start of any event. We often call upon the ancestors we know who were courageous and wise and who could add their energies and strengths to the process. They could be a legendary ancestor known by many for their merits, or someone who we knew privately in our family, whose character and talents we could be helped by. We sometimes invite unseen beings who may already be witnessing anyway, and who may need what we plan to provide in terms of knowledge, strategies, love, and healings. It is a gathering of the spirits. We collectively say Ashe at the end of speaking a name or a group description or a concept to give it power. I ask you all to get comfortable, be relaxed, take deep breaths, close your eyes if you like. If you don't like, it's okay. And think of the name of an ancestor you'd like to speak aloud. It's okay, we're gonna hear a number of names, but let us all take at least one or two and say them. And then I'm going to gather the other spirits who may be present, who we may be speaking to today. So I'll start with my grandmother, Celia Brown Hines. Ashe.
Hazel Veronica Warner.
Ashe.
Rosa Blaine Spears.
Ashe.
Charles Oliver.
Lucy Northern, my grandmother.
Ashe.
Estelle Sargent, my grandmother.
Ashe.
Latina Comer.
Ashe.
Wilfred D4.
Ashe.
Edward Sargent, my grandfather, my father.
Ashe.
Rosa Baker, my grandmother.
Ashe.
Alvin Adams, my cousin.
Ashe.
Ida Blossom, my grandmother.
Indira Stevens.
Ashe. A few more.
Oliver, my father.
Ashe.
Ruth the Four.
Ashe.
Mary McLeod Bethune.
Ashe.
Bernice Gardner.
Ashe.
Raymond Hill.
Ashe.
Mama Susan Woodson.
Ashe. And now let's get into the gathering of other spirits unseen, who today we're here for. And Ashe to all who was spoken of. Let's be here for the slaves who could not cope with being ripped from their families, 14 to 8 and torture of the slavery system. And after losing their motherland, their freedom, and their family members, they lost their mind. Ashe.
Okay.
This is Mental Health Month. We're here for an event for Black Mental Health Month as well. Let us be here for those who were institutionalized in psychiatric hospitals, some with mental illnesses and some without. Those without, why were they placed there? Ashe. For those who tried to leave through the hypocrisies and live through the hypocrisies and inequities of the Jim Crow era, which saw them as less than human, so they began to doubt their worth and sanity. Ashe. For those who bore witness to troubles and horrors so evil and vast that traumas from those troubles and horrors reverberated through them and their children's children's children to the present time. Ashe.
Ashe.
For those who found no justice and no mercy from a system constructed to drain the manhood and womanhood from them and crush them until they lost their minds. Ashe. For those with classic mental illnesses who sought help from mental health professionals, who misdiagnosed them, over-medicated them, and sometimes neglected and abused them. Ashe. For those who were killed because they encountered police or others who didn't understand the conditions of mental illness and what they needed. Ashe. For all those who were ashamed to admit that they had a mental illness and failed to ask for help or didn't know where to go for help or were afraid to go for help. Ashe. For all those who kept their sanity in the face of unimaginable insanities and who continue to seek the light. Ashe. And for us who are here, who've come to understand, to help, and to heal. Ashe. May today's program offer a beacon of light to us all.
Thank you. Thank you so much for that beautiful libation, Dr. Hines Zami. And I would like to just invite everyone at this time to really open themselves up to candid dialogue. My name is Dr. Jamila Codrington. I am the current chair of the Program Planning and Development Committee. And on behalf of the board, we welcome you all to today's program. We will be talking about reducing stigma by coming out of the mental illness closet, a candid conversation with Dr. Lisa Whitten. I want to just say a little bit about the inspiration for this program. All of you probably know that May is Mental Health Awareness Month. And with the New York ABSI focusing on the health and healing and well-being of people of African descent, for us, Mental Health Awareness Month really is an opportunity to think about how can we really double down on issues affecting the mental health of people of African descent and any barriers to the pursuit of wellness. And we have known for decades that one of the primary barriers is the stigma, right? Is the stigma associated with mental health services. And historically, people of African descent, we have normalized our own suffering, and other people have normalized our own suffering. We know the history of enslavement and the inhumane lifestyle, including, frequent beatings and abuse and being forced out of our homeland. And one of the things that had come about from that in terms of the psychological residue is equating strength with survival, right? Weakness was sort of this space that created victimization. And so we think about what it means to break free from some of these cultural narratives and from also some of the cultural stereotypes that have been placed upon us. And we also recognize that the stigma still exists today. And many, many people of African descent are struggling in silence, feeling socially isolated, feeling like they can't necessarily trust anyone. We understand that there's also a history of medical racism in this country. So they go at it alone. And we understand there's also systemic barriers to accessing healthcare and accessing culturally syntonic healthcare by providers that look like us. So the statistics are there, it's loud and clear. African Americans are 20% more likely to report having serious psychological distress, according to the US Department of Health and Human Services. But especially those with higher education, we're less likely to seek out mental health services than our white counterparts. So we need to understand what is happening beyond some of the dynamics that you've read about and talked about in the literature. And so we bring you closer to the conversation by really opening up a dialogue with one of our past presidents, Dr. Lisa Whitten, who is here to talk about her own journey with mental illness. And this is the inspiration of this program today. Dr. Whitten published an article in 2020 called Stigma Matters. An African-American psychology professor comes out of the mental illness closet. So we get to have her live and direct here today to talk about, through an interview format, followed by Q&A, and then some breakout sessions, what it really means to break stigma from a personalized account. So at this point, I would like to introduce our current president, Dr. Dana Collins, who will be facilitating the interview.
Hi, thank you, Dr. Codrington, for that opening and sharing with us why we're here, reminding us of why we're here and why this is so important. And to Dr. Whitten, thank you for your openness and your authenticity and your willingness to be able to tell your story. A lot of us have fears and trepidations about talking about our struggles, our mental illnesses, but it really is important in order to help others feel that it's okay for us to know that it's okay. And not only is it okay to talk about it, it is okay to get help and that we should get help. And I want to say that I feel really privileged and honored to be helping you in telling your story, sharing your story. And I also want to thank each and every one of you for being here. I know that the weather here in New York the weather has come a long way. The COVID restrictions are lifting, so there's a lot of other places you might have been, but you're here with us, and we really appreciate that. So, Dr. Whitten, I have some questions I want to ask you, but before I do that, I'm wondering if you wanted to just share a few words about yourself.
Yes, I'd first like to thank all of my colleagues, friends, and family who are here today. I really appreciate your presence. Many of you served as anchors for me when I was having difficulty 20 years ago. I'm really looking forward to sharing my experience. I decided to talk about my experience in part because self-disclosure is not that hard for me. Sometimes I have to really rein myself in, but I really felt that since self-disclosure isn't that hard for me, and I didn't grow up in an environment where mental illness was stigmatized. In my family, it wasn't. I knew about it. I knew that there were treatments for it and that sort of thing. Mm-hmm. But I just wanted to, what I'm hoping we'll do today is to emphasize from a subjective point of view. I've been using the word subjectivity with my students. We study, like you said, Jamila, we read the books and the DSM that tells us how to diagnose people, but we need to pay more attention to the internal experience, the what Linda and I called in one of our articles, the internal dialogue that's happening and how that impacts a person going through journey, and that's what I'd like to share with you. You'll be able to read the article once we post it on our website and get more of the details, but we'll have I'm sure a very interesting and stimulating conversation today, and I'm excited to be here.
Yeah, I'm excited for this. I'm wondering if you can say just a little bit about what bipolar disorder is, because I think it's one of those words that really gets thrown around a lot and misused, and people really don't understand. So for those of us who are not mental health professionals, could you just speak a little bit about what it is?
Sure. Bipolar disorder is a complex cluster of conditions that people can experience. The bi means two and the polar means two poles. So people with bipolar disorder vacillate in terms of their mood from manic to depressed. And there's a whole range in between. So often we think of normal being in the middle, and on a scale that I used to use to rate myself, 5 was normal and 10 was manic, and then 10 down here was very depressed. So there are some people who vacillate mainly between depressed and normal, others between manic and normal. Some only go up to what we call hypomanic, under manic, and there are other fine details, but that's essentially what it is. Some people have what's called rapid cycling, and they go from one mood to another very, very quickly. So that's essentially what it is. And now people are saying, oh, I'm feeling bipolar, I'm so bipolar right now. And it can carry a really negative picture, image of someone just out of control, I guess. But that's not so far from the truth. When you're in the middle of a manic episode, you can really, when I was in my manic episode, I felt really out of control. And that's essentially what I would say.
Mm-hmm. Yeah, and I appreciate how you talked about both as you said, your subjective experience and some of what we might see overall in bipolar disorder. Mm-hmm. Thank you for that. So I next want to talk with you about the title of this event, Coming Out of the Mental Illness Closet, Reducing Stigma. It's a really rich title. There's a lot there. The idea of coming out of the closet is usually something that LGBTQ folks talk about in their mm-hmm. experience. And then there's the word mental illness, which a lot of us don't like to use. So yeah, could you talk to us a little bit about the title?
Sure. I use that idea, that notion, in part in solidarity with LGBTQ plus folks who, many of whom live closeted and hide their true self. And I found that was something that I did quite a bit when I was younger and depressed. I would, I often say I'm a good actor because I have pretended to be not depressed so many times when I'm teaching and when I was seeing patients. And just, I wanted to talk about the energy that it takes to maintain that cover, and to talk about how if more of us can talk about it and make ourselves vulnerable and come out of the closet, it could help us to deal with some of these issues and get people to feel more comfortable looking for treatment. Mm-hmm. Everyone's coming out experience has to be different. It took me about 10 years to talk about my experience publicly at an Association of Black Psychologists convention. And and then another 10 years for me to write about it. So it's not an easy process, as other people know who have come out of the closet in other ways. So that's the main reason. And then we're using mental health much more these days. And that's important because we want to think about mental health, again, existing on a spectrum. And people who are mentally ill are not mentally ill 100% of the time, even people who are in facilities. You can see glimmers of health, and it's on a spectrum, but mental illness is something that exists, you know, and so I wanted to make it more easier to use that word, because I did feel ill when I was in my manic episode. Yeah.
Yeah, so you really touched on a lot there. And one of the last things you said was that we need to be thinking about mental illness as something that's on a continuum. It's not this either or black and white thing. So expanding how we look at it. And I also really appreciate what you said about the energy that it takes to hide ourselves and not be our true selves. And I think that really does a disservice not only to us, but to the people around us, because then they don't really get to know us and they don't get the benefit of knowing us. So thank you for that.
And they also don't have a chance to offer you help if they don't know that you're in trouble.
Excellent point. That's absolutely right. Yeah. So when did you first know that you had a mental illness?
Well, it's a long story. I believe I struggled with depression when I was a child. And my mother tells me that when my grandmother would come, or at least one time, she said, "Eloise, don't you think Lisa looks kind of sad?" And I remember feeling sad, and I had a lot of social anxiety when I was a child. I was very extremely self-conscious. I was okay in my family and with friends, but once it opened up some, it became very, very difficult for me. And then as I got older, and I think I had my first major depression when I was 13. And I just was aware that I was feeling even more sad, having more sense of helplessness, and just sort of feeling trapped and unable to move forward, and you know, just those kinds of things that were really troubling. And so I would say in my teens, I began to realize that I really was different from other people in some ways, and that I was struggling with depression that would come and go. The bipolar disorder wasn't diagnosed until quite a bit later, in my 40s. And it happened in part because of my genetic predisposition to having mental illness, and bipolar disorder in particular. And I have learned that my manic episodes started in 2000, pretty early in the year. And then when I changed my antidepressant medication, which I started taking in my early 40s, I was sort of pushed, not sort of, I was pushed into a manic episode, because the medication that I was given that was supposed to be that was supposed to be a mood stabilizer really acted like an antidepressant. Right. So I just sort of took off, you know, after being on that medication for a while. And it took quite a while to get myself stable again.
So it's been really a journey, and it sounds like you first knew that you called it different in your teens, but even when you were young, there was a lot of sadness. And I think that really speaks to or challenges the idea that a lot of people have that children can't be depressed, children can't have mental illness, children can't experience these things.
Yes. When I was growing up in the late 50s and early 60s, the field of psychiatry and clinical psych really didn't acknowledge that children could be depressed. So that came about later.
Yeah, right. So can you tell us what helped you to accept that you have a mental illness? You obviously are at a point of some acceptance now, having written an article, doing this event with us. When did you first seek help in your journey, and what did that look like?
I tell the story about being at the University of Michigan. I was depressed on and off. You know, I was normal most of the time, but I would go through weeks and sometimes months of being quite depressed. The type of depression I had was pretty much internal, and it didn't cause me to, I was still able to function, okay? Again, depression exists on a continuum too, and some people become so depressed that they literally can't get out of bed. We know that often people attempt suicide or complete suicide. So it's, again, on a spectrum. But when I was at Michigan, I said to myself, Lisa, come on, you need to do something. This is going on for too long. And I went over to the mental health center. I don't know what they called it at the time. I remember I was about 19, walking up to the door. I saw this rack of pamphlets and everything. I think I took a couple pamphlets off of there, and I turned on my heels and walked away. I wasn't able to go in or talk to anybody. So this, even getting help, even though I knew that people in my family had received mental health services, I feel like I wasn't stigmatizing them, but there was still some stigma inside of me. And it took, I ultimately started psychotherapy. We had group psychotherapy at my graduate school, the Derner Institute, and I also started individual therapy then. And I've had many, many years of therapy and all kinds since then. And it's been very helpful.
Yeah. So you talked about the first time that you really sought help was a counseling center, and you left pretty soon after. Was there something that
I didn't go in. I never saw anybody at that mental health center.
And I see. And do you think there's anything that could have gone differently then to keep you there, to help you to stay?
That's a good question.
That anybody could have done?
Yes, I think if there had been someone outside to greet people who came and to talk to them even before any intake process and say, oh, what are you here for and what's going on? I don't remember anyone being there. It was a long time ago now, but I think that could have helped. And perhaps if they had come to what we call then dorms and talked about the availability of services, I presume they told us about it during orientation, but I certainly don't remember. I think that could have helped too.
So having someone to reach out, someone to meet you where you were and guide you to where you needed to be.
Yes.
So sort of speaking of that, in that same vein, do you have any advice for family members, coworkers, friends who have someone whose mental health they are concerned about? And part of the reason I asked that also is in your article, you talked about the sort of how people react, the people in your life and how they reacted to you.
Yes, yes. I would say the main thing is to listen, really listen carefully to what the person is saying. It's not always easy. When I was in my hypomanic and then manic episode, you couldn't tell me nothing. You know, I just, at first I felt great. Everything was exciting and stimulating, and I was having fun and talking to everybody. Very different from what I call goody two-shoes Lisa, who was really quiet and hardly said anything and, you know, didn't speak up all that much. It wasn't very assertive. And I couldn't, you know, it was hard for people to reach me, but I want to encourage people to just really persist. And one of the things that helped me, people, I think, who go through an experience like I did, really need an anchor. They need someone to help them be grounded, to help them be in the moment and not flying all over the place. And some of the people who helped me do that are in this Zoom room. What helped often was when someone said, Lisa, I'm not going to let you do that, okay? I had written a letter to the administration at my school because they had sent people to the chair saying, what's wrong with Lisa? And I wrote this whole letter about, if you want to know what's wrong with Lisa, the next time you need to come and just ask me. And I showed it to my friend and she said, Lisa, I won't let you send that letter. And I didn't send it. So boundaries, really, really firm boundaries. And one thing I want to say is that if someone is on any kind of medication, but psychopharmacological medication in particular, if they have changed that medication and you know that and then their behavior has changed, pay a lot of attention to that medication, because that's one thing I fault my psychiatrist with. He changed the medication, my behavior changed radically, but he didn't change it back or really assess what was going on. My mother and I went to see him and my mother told him all the things I was doing, how I was arguing with people and disobeying rules that could have gotten me in trouble, and how they were concerned about my career and so on. And he didn't do anything, you know? So let's see. I think trying to really understand the subjective experience of the person. As I say, when I was in my hypomanic phase and moving into the manic, something about the medication I was taking or the frame of mind I was in really removed a lot of filters. My judgment filter was gone. Now, not completely gone. I didn't get into major trouble, but I got into some trouble. My pain filter was gone. And I was having pretty severe joint pain. It felt severe to me. And nobody wanted to pay attention to that. And that was the most important thing to me. And one friend of mine, when I would tell her I'm having pain and I don't, you know, it's been very unpleasant, she would come over and massage my neck. That was so important, you know, the hands-on and the really acknowledging what I was feeling. I'll say one more thing. I think this isn't something that was done, but something that I think could have helped. That would have been some sort of real intervention. My sister says that she had alerted everyone who was important in my life in Detroit. A couple of the mothers of good friends of mine and, you know, a few friends who were still there, and said, Lisa's coming and we need to have a meeting with her. And she was going through a very difficult time at that time, going through a divorce. And there was a lot going on. And I don't know what happened, but we didn't have that meeting. I think that could have made a big difference. One of the things I just want people to think about is that it's important to do something to let the person know that you recognize that they're in trouble and to try to get them to help. Maybe, I could go on and on, but I think an intervention of that sort could have helped. And seeing all those people that were important to me could have helped ground me. Everybody needs something a little different. But just like what we're learning with people who say that they are thinking about suicide, we need to always respond because we don't know how likely they are to do it. And I think that's true when someone is letting you know that they're in a great deal of pain. Like when I stood up and started screaming in a department meeting, which I didn't do that, you know, and that was a mental health emergency. And if I had just fallen out as if I was having a heart attack or a stroke, people would have known what to do. They would have called the student health, gotten 911, you know, called 911, gotten an ambulance. But people didn't know what to do, even in a psychology department. And so I think we need to talk more about how to help people who are in crisis, even in the workplace.
You know, and so much of what you have shared just has to do with being in a relationship with someone, listening to them, being attuned, asking them what they need. And, you know, even when they don't know what they need, just sort of watching out for them. Mm-hmm. And, you know, it doesn't have to be, we don't have to be fully trained, licensed mental health professionals to be able to do that. A lot of it, as you said, is just about watching and being concerned and expressing concern. And then you also talked about the importance of having a safety net. It takes a village.
Yes, and there are a number of people in my village who are on this call, and I acknowledge them at the end of my article, because without them, I might have been in even worse trouble.
Well, thank you. I don't really know how to express my gratitude for what you've shared with us today. And I think we're going to be moving into breakout rooms in just a few minutes so people can talk more about what you have shared. And we can also talk about some specific things that we can do to be responding to mental illness and combating stigma. But before we do that, I'm wondering, Dr. Whitten, is there any last words of wisdom that you want to leave us with?
I'm just going to look at my notes over here quickly.
Sure, please.
Notes make a big difference for me. I want us to think about not being afraid of people who are mentally ill. There's so much fear, and I think also people are afraid because they're thinking, well, maybe I might have something like that going on. But to just get more comfortable talking about it and recognize that people with mental illness are less likely than people in the general population to be violent, and that if you sit and talk and listen to people, it can make a big difference.
Thank you. Thank you. And I see that a number of others have expressed their gratitude. So this has made, I think, a real impact on us. So we will now, we'll now move to the next portion.
Well, are we going to have a couple questions from people?
Yeah, I think that's right.
Right now? Okay.
So first, just on behalf of our community, Dr. Lisa Whitten and Dr. Dana Collins, we want to thank you for such a powerful conversation about what it means to live with mental illness, and to be able to really lean into it and understand what it means to engage in a healing journey.
Mm-hmm.
And there are over 60 people on this call, and I'm sure everyone knows someone that could benefit from this information, if not themselves. Mm-hmm. So we want to give the community an opportunity now to have you answer any additional questions that may not have come out organically in your candid conversation. Mm-hmm. So I'd like to just share a couple of comments that have come through the chat, and I'd like to welcome those who have joined us since the very beginning. And you still have time. If there's a question that you have that you'd like Dr. Whitten to answer, please drop it in the chat. So there's a question here about out of control. That was something that you mentioned. Can you unpack that? Can you describe what that looks like and feels like? You mentioned that we are here to not reiterate what's in the DSM, but to bring lived experience to symptomatology. So what does that look and feel like for you when you are out of control?
For me, it felt like having many thoughts going through my mind, having a lot of difficulty getting to places on time. Again, the boundaries were just not there. It was having thoughts sometimes that were irrational. I think at one point I remember just talking sort of a little bit of nonsense and talking about, I had lost a key. And I remember talking about another situation where I lost a key. And I think I might have been a bit psychotic at that point. I was not right there in the moment in that hotel. I was talking about losing my key somewhere else. So it showed up in a lot of ways. It was just hard to get things done and to keep my apartment straightened up and to remember what I was supposed to be doing. And again, sometimes I was on my way to a trip to Ghana, and my late boyfriend, Steve, was concerned about me going because I was in that state. And he said, Lisa, I'm not going to let you go to Ghana without your mother. And I said, what do you mean? I'm a grown woman, I can go, I know what I'm doing. And he just used the broken record technique and kept saying that. And ultimately I agreed for my mother to come after a couple weeks. So again, when people helped to ground and anchor me, often I was able to respond, not always.
Thank you. And that is a perfect segue, Dr. Whitten, to another powerful question that came into the chat, which is really about this anchoring of yourself that you experienced from your community. So the question is, first, thank you kindly for this. Please provide insight about what should the anchor person or mental health professional do when the out of control individual threatens or tries to harm them, for example, in the hospital, in jails, or delinquent settings.
When they threaten or try to harm them, someone working in that setting? Well,
yes, working in the setting.
What needs to happen is that people need to receive training about how to respond to people who are violent or might become violent. I remember learning that you should show your hands and make so that they can see that you don't have a weapon or anything. You have to really drop your voice and talk very calmly. And there are techniques that they illustrate where you can go behind the person and grab them and then pull them down and sit down. It's going to depend on the setting that you're in. But I thought you were going to talk about anchoring someone outside, because people need to be assessed again for suicidality and whether they are perhaps having a homicidal ideation. And in that case, they might need to be hospitalized. But I hope I'm answering your question.
Yes.
Mary, did you want to refine it anymore, or do you feel like that was addressed?
Yes, that was addressed.
Okay, thank you, Lisa.
And we know that this is a huge problem in our communities with the police. They don't know how to respond. They escalate instead of de-escalating. So it has a lot to do with de-escalation. And that's another word you could use with when we're thinking about some of the people that helped to ground me, was to use de-escalation and get me to calm down.
Yes, thank you, Lisa. And what's interesting is that only now in New York, they are moving towards having a brand new program where instead of law enforcement officers coming out with emergency calls that are mental health related, they have a trained mental health professional, right? So we are finally starting to see systemic changes, but it took a long time for something like that to come along. And there's so many other exchanges that happen in systems of care where police are not called or 911 is not called, and we are lacking properly trained individuals on how to assess a situation and de-escalate. So we really do need to talk about advocacy on a systemic level. And as we move forward with the dialogue today, we'll have an opportunity for a breakout session specifically focused on advocacy for public policy.
I'd like to share something. Dr. Hines Zamni asked whether medication or psychotherapy helped me the most. And I want people to know, I know that many, many African Americans are opposed to medication, psychotropic medication. They feel like it's been given to us way more than it should have, and it has. I have found the medication tremendously helpful. That huge mistake that was made by that one psychiatrist and my not getting to him soon enough or saying enough to get him to change the medication that caused me to have a terrible year, and my family and my friends were all suffering with me. But I've been on essentially the same dose of antidepressants and mood stabilizers now for almost 20 years. And I don't get depressed. That's not accurate. I get depressed, but it lasts for a day or two. And if it lasts for a little longer, I'm able to titrate the medication up and get out of it pretty quickly. It doesn't last for weeks and months. The psychotherapy was also very helpful. They were both helpful. I didn't start taking the medication until I was about 43 or 4. So before that, it was all psychotherapy. And I think that adding the medication made a huge difference in my life.
And there are so many reasons which extend beyond the bounds of this conversation why many people of African descent are a bit wary of psychotropic medications, and even psychotherapy, right? Especially with finding a culturally appropriate provider. Pat asked a very powerful question related to this. People are suspicious and hesitant about medication and mental health. Can you speak more about this and advise those in the audience who are in need and struggling? So for people, it sounds like the question is for people who really do need mental health treatment, either therapy or medication, but there's suspicion around it and they're struggling. What words of advice can you offer?
Yes, I would say that it's not easy. I told you about my attempt in college to get treatment. It takes time, get a lot of information, ask a lot of questions, and don't try, if you have an experience with a mental health professional that isn't up to what you were hoping it would be, try someone else. Try someone else. It's a process, and you don't always find the right person. Just like when people are looking for life partners, you don't find the right person right away necessarily. And I want to say that I know many African American and African descent people want someone who is African American. There aren't enough of us to go around. We were talking about this just before we started, that Jamila said Dr. Codrington said her practice is full. When I had my small practice, I always had to turn people away and help them find someone else. You might have to see someone who's not African American, and you can find someone who is attuned to our culture and the experiences that we have through someone who is African American. So I just want to say, it's a little controversial for me to say this, but we don't have enough African descent mental health professionals. We're getting more as more mental health counselors are being trained, but I just want to say that it's possible to receive high quality treatment from someone who is not African American. That's my belief. I have received it.
So we have another very beautiful question in the chat that taps into this understanding of differential, or this question really about differential treatment depending on the type of provider. Dr. Whitten, can you talk about how you were impacted differently by treatments of professionals depending on their African-centeredness, their cultural competence, their caring, their lack of caring, or their lack of cultural competence? Do you have experiences that run the gamut? Can you share a little bit about the differences?
I've never had a therapist who was African-centered. I did get a lot of sort of osmosis type treatment by going to ABSI conventions every year for 40 years. And I learned a lot about that and absorbed a lot of those values, but I didn't ever work with a therapist who was African-centered. I did work with several African-American therapists, and I don't know how to characterize it. For me, it had more to do with how much they were able to empathize with what I was going through, and how much they were able to help me translate my feelings and my frustrations into action. You know, one therapist taught me deep muscle relaxation, which I still use. He was Jewish. Another therapist, one of my Black therapists, I think the Black therapists tended to be a little tougher, a little harder hitting. And my most recent one said, well, you say that you want to find a partner, Lisa, but you don't seem to want to do the hard work. And I was like, wow, nobody had ever said that to me. And so I said, yes, I do want to do the hard work. I want to do the hard work. And, you know, I started doing the hard work and I found my partner. And so I personally think that for many people, it's more about the personality of the individual, but that if someone really, really needs to have someone of the same race and culture, then we should do whatever we can to help them find that person. Because for some people that they just won't go. I remember being in college and a friend of mine saying, I'm not going to that counseling center and talking to those white people. She just was not, if the person was white, she wasn't talking to him. So I know that's the case. And that's why we need more psychologists and why we're working through ABSI and New York ABSI to get people excited about the field and get some more people involved. I see our time is really moving.
Yes, I do want to just be able to ask this final question, because we understand that from an African-centered perspective, healing is holistic, and it's not just from the standpoint of mental health treatment, therapy, medication.
Yes.
There's a question, thank you, Afua. Have you used non-conventional approaches to healing in addition to psychopharmacology and psychotherapy? So you did talk about progressive muscle relaxation. Are there other non-conventional approaches that you've attempted, and what has been the impact?
I've practiced yoga. That's one thing I can say. I'm one of those rare Black people who didn't grow up in the church, not the Catholic Church, not the Baptist Church. We went to church at times, so the spiritual aspect was not really so much on the radar screen for me. But again, through my experience with the Association of Black Psychologists and learning about African-centered treatments there, and the importance that so many people have about spirit, the importance of connecting with spirit. And for me, connecting with my ancestors is one of the main ways that I do it. And so I would say that now I use meditation, and I frequently call upon my ancestors to help me. But other than that, I have not had, my father was a physician, and I was taught to believe in the medical model. So I believed in it, you know, and it caused me some problems, but it's also helped me. So that's the answer to that question.
Mm-hmm. Thank you. There is another question that has to do with self-disclosure among therapists in healing others. And I would like to actually invite that to be one of the things that we actually discuss in one of the breakout sessions. So thank you, Linda, for your question in the chat on that. We are running out of time, and we want to be able to actually be solution focused.
Yes.
We're not just about analyzing the problems, but we want to generate committed action around breaking stigma and breaking the silence. So at this point, we would like to invite small group discussion amongst the family here. We have a number of breakout rooms that you can join based on what resonates with you. And the goal of these breakout rooms is really to come up with strategies, real strategies about what we can do, what's within reach, right? And what are some ideas systemically that we can do, we can engage in order to really decrease the stigma with respect to mental health issues in the Black community. So the breakout rooms will be faith-based institutions. So what strategies can faith-based institutions engage in? We will have a policy room for people who are interested in more systemic public policy issues. We will have a New York AB Psi room. As an organization, we are committed to being a part of the solution. And this is why we are here having this dialogue today. So for those who would like to dialogue around tangible solutions and strategies that we can take on as an organization, please join the New York AB Psi room. We will have a family and friends room. So this is for, the committed loved ones who are looking to support their family members and their friends. What are some things, some real strategies that can happen there? And then the media, right? The media has such a powerful role in shaping the ideas around mental health and shaping the ideas around what it means to pursue treatment in mental health, particularly for the Black community. So we will have a media room where we talk about mainstream media and social media. So I would like to invite us to have about a 10-minute discussion, and then we will come back as a larger group and share out some of the themes that came out from our breakout sessions. Welcome back, everyone. We really do hope that you had some stimulating dialogue in your respective breakout sessions. And we have an opportunity now to just do a go round and hear about some of the ideas that got generated. So let's start first with the faith-based institutions. If there's a representative from that breakout room who would be willing to share some of the ideas and themes that got generated, please come off mute and share.
Hi, Dr. Condrington, I'll share. So the group was actually a very lively discussion. A few things that came out of our discussion today was this idea of really using the church not only to help prepare the next generation and focus on youth having more education and awareness of what mental health is and how to access it as a preventative, but also opening up the church to have these conversations with people who've been members for a long time and with our generation and generations before us, as there tends to exist more of a stigma with the older generations, and the younger generation seems to be a little more comfortable talking about things, just not really sure where to go. And so on the part of the church, having this space created by church leaders, by youth ministers, but also on the part of us as psychologists being involved in different faith-based organizations, making sure that we get in where we fit in, so to speak, putting the information out there and not waiting for people to come to us, and taking any opportunity to share information that might be useful to members of a faith-based organization.
Great, thank you so much, Dr. Dodd. So any other ideas that anyone else from the breakout room for faith-based institution wants to share, or does that feel like it captures it? All right, thank you. So let's move on to media. Can we have a representative from the media breakout room share your collective thoughts?
Hi, it's Catherine. I mean, I took a couple of notes. We did talk about how the police, it's like the police, how violent they are toward, obviously, our people who may have mental health issues. And I think we were a little bit stuck on, given the power of the police unions, just how hard it is to make change about, around the policies of the police. I mean, obviously there is that pilot program, I think that's in New York and in other cities where there are mental health professionals who are being dispensed, to help out people having episodes. And that's good. But then we talked a little bit about school as a place where, there are teachers who are calling the police and having 5-year-olds pretty much arrested. There's obviously a double standard. And it's like, there are public schools, and there are communities that send their children to these schools, and maybe making some sort of presentation to the various schools about how to handle what seem like discipline problems that really could have its root in mental health issues. That again, schools are a pretty good place to try to make some changes. But anyone else from the group want to add to that?
Yeah, we also talked about disentangling these media representations of mental health as equated with violence, because a lot of that's a lot of what we're seeing. And we talked about ways in which that could be done, possibly op-eds, possibly Instagram bits where because you've seen those representations where talking about something, but there's short phrases and stuff about that. And we talked about also the possibility of some of our members who have actually had podcasts and things where this kind of, we could disentangle those on a podcast that could be shared. And because there's some members, not locally, but that have podcasts that possibly some of us may be able to go on and do that, have that discussion.
Thank you, Dr. DeFore.
Yeah.
All right. So just in the interest of time, let's move forward. Family and friends, can we have a representative from your room share your collective thoughts?
Alice and I were both in that room. Alice, do you want to go ahead, or would it be okay if I do?
Would you like to, Denise? Please do.
Thank you. We got together, each one of us gave at least one solution or one strategy that family and friends could use to help someone who was suffering within their midst with mental illness. And some of the ideas were, don't leave them out of family gatherings. Don't do that. Don't let them isolate, which they have a tendency to do. Give them love. I mean, that was a simple statement, but that's definitely needed. Call them regularly. I mean, if they live somewhere else, make sure you give them a call, maybe once a week. How you doing, Listen to them is one of the things that came out. Don't just, say, okay, really listen, even if it doesn't make sense at the time. Let them know someone cares. Visit them if they're institutionalized. Take them out to lunch when they are deinstitutionalized. These are some of the things we came up with. I think everyone contributed quite well to the discussion. I'd like to add something, and I know we're running out of time. In the media group that got together, they mentioned about units going out to people who are in distress and going through mental health crises. I've found that these mobile units that used to go out are now affected because of COVID-19. I'm wondering if anybody else has experienced that. They're not willing to go up to the individual anymore, so I don't know what things are happening differently, but that has been a tremendous burden.
Thank you, Dr. Hines-Ami. We do have 2 other groups to get to, and I know we're coming up against our time boundaries. So let's transition to the organization, New York AB-Psi. Dr. Collins, would you like to report out? You were in that breakout session and help to facilitate.
Absolutely. So I'll touch on just some key points. The point was brought up that there's sort of a cluster of mental health months, and it's great. This is something that's come up before, but it's great to do programming and event sharing and information sharing during those months, but it can be and really should be something that happens throughout the year, and maybe there can be some follow-up at some point after the events to see how people have moved forward or how people have used the information. There was also the point about sort of breaking down silos and working with other community organizations to spread awareness, whether that's with arts groups, with schools, and in addition to having programming, maybe putting out other forms of media such as infographics. There was also a point about continuing to do self-disclosure, and in addition to doing self-disclosure, talking about what has worked for us. So the point came up that people are already very reluctant within our community to access mental health services because and when they do, they feel that we should have it together as providers. So it's very helpful to normalize that we don't always have it together. It's okay to not always have it together, but this is how I have kept going. This is how I have been able to cope.
Okay, thank you, Dr. Collins. And we will close out this segment with our public policy breakout session. Can we have a representative share thoughts that emerged from that breakout room?
Sure. I'll just kind of summarize. So basically, there were two trends that came out from our policy discussion just briefly, and one of them was really focused on workforce development issues. So when you look at the need for therapists of color in our communities, how there seems to be not enough, and then look at it from a policy perspective, what can be done to increase the workforce in terms of psychologists of color that can do the work within our communities. And then the second trend that came up basically was, how can we increase the number of students of color into doctoral programs to become psychologists, and understand that there's a big need from a policy perspective for that, but also what can we do to support that? So things like loan forgiveness programs came up, things like incentives financially to increase the number of students of color in doctoral programs that could also help in terms of the future, in terms of clinicians, in terms of psychologists that could serve our communities. So those were the two major trends that came up. And I'll just open it up for anyone else that was in the room, just in case I missed anything. But those are the two major things.
Any other thoughts from the policy room? No? Okay.
No, it occurs to me that I want to mention that Brother Pearl and I are on the ethics committee for the National Association of Black Psychologists, and we have worked over the course of a few years to revise our ethical standards and incorporate the principles of Ma'at, ancient Comedian principles, and you can find that on our website in the not too distant future. I think it might be there now, and I just wanted to make sure you knew about that. It could be useful.
Great, thank you, Dr. Whitten, for mentioning that. And we also want to make sure that we provide just a few resources for the community with respect to this. So I'm going to ask at this point, Dr. Charmaine Dodd to just come off mute and share a little bit about some resources that could be helpful. And she's one of our committee members for the Program Planning and Development Committee, as well as Marcus, who just spoke.
Thank you, Dr. Codrington. So I just wanted to share a couple of resources that might be helpful to you or someone that you know who may be struggling. The first is the Unapologetic Guide to Black Mental Health by Dr. Rita Walker, and I will include the link for this in the chat for anyone who's interested. It basically goes from A to Z, how to enter into the system, how to search for and find a therapist that may be a good fit, and also what to look for in getting good therapy. For those interested in those alternative methods, and I know that Dr. Whitten mentioned yoga, I'm a big advocate for yoga as well. We have a book here by Dr. Gail Parker, which is Restorative Yoga for Ethnic and Race-Based Stress and Trauma. Very good book on explaining how yoga can manage and help you understand the trauma that happens to our bodies. And then lastly, for anyone wanting to do just a little bit of self-research, either during your therapeutic process or prior to going into therapy, a good book for helping you get an understanding of what trauma does in our bodies and how our experiences affect our bodies is My Grandmother's Hands by Resmaa Menakem. So I'll share all of these links in the chat for anyone who's interested.
Okay, thank you, Dr. Dodd. And Dr. Collins, would you like to just close us out?
Yes, again, a very heartfelt thank you. I know that we have thanked our community for many, many times, but we are really grateful. Not only that you are here with us, but that you have made the commitment to share your ideas and help us to continue doing this really, really important work. Just a couple of announcements I want to make. As Dr. Whitten said, we will be posting information about accessing the article on our website soon. We're not able to directly share the article because of contractual and legal things that we don't want to get involved in. The other thing is that we are going to be holding our board elections very soon. So we have a number of officer positions that people will be able to run for that we're looking to fill. So stay tuned for that. I also want to, as always, invite new members to NYABSI. So it's clear that from this conversation, there is a lot more work to be done and there is a lot to be gained. So I want to put out a plug for that. I'm going to just drop the link in the chat for joining us. And even if you're not quite ready to join, you have the option when you go onto our website of joining our mailing list and keeping in touch with us. I will leave it at that. Thank you all so much. And of course, Dr. Whitten, as I said, there really aren't enough words to thank you for your openness and your willingness. And you have just very obviously given a lot of us a lot to think about and have been inspiring to so many. Thank you.
Thank you for having me and giving me the opportunity to speak in this setting. And it was so, we complain about the Zoom meetings, but look how many people were able to come from all over the country. Kathy, Dr. Giscombe is in California and Brother Pearl is in Minnesota, and it's just been great to have people from all over. And my thanks to our national president, Dr. Jackson, for being here. And just thank you to everyone for coming and staying through the discussion and participating. Really appreciate it.
And we have a sister who is in Ghana. So we are international. Thank you, Eileen. Thank you all for coming on behalf of New York ABSI. Have a blessed rest of your day. Please continue to join us in the future. Take great care.